My hip hurts because of the way they're positioned in surgery. So the more you can find out about your surgery patient, the better you can answer their questions when they're telling you that they're in pain, okay? Because when I say, oh, I'm hurting, what does that mean for this patient? Is your abdomen hurting? Are your incisions hurting? Does your shoulder hurt because of the way you were laying? I need to find out what's going on. We're going to talk about adrenoectomies in level 4 in depth, but I want you to think about this. If I am removing a part of the kidney where there is a lot of blood pressure control happening with my aldosterone and with my anti-diabetic hormone, what do you think is going to happen to my patient's blood pressure?
It's going to drop.
It could drop. Or if my patient all of a sudden in this very vascular organ has bleeding, it could go up or down. So my blood pressure can be affected either way. So when my patient comes to me from surgery, I want to be monitoring my blood pressure and pulse pretty routinely to make sure that there's not a problem. We're going to talk about it in depth when we go into level 4, but I just want you to be aware of the surgery to correct it is the adrenoectomy. We're going to talk about this when we talk about pheochromocytoma in level 4. Don't write that down. You don't need it. I saw your pen.
So in this one,
You don't know how to spell it, for one.
in this one, you're removing just your.
I'm removing
adrenal
either the
gland.
tumor. No, I'm removing the tumor or whatever's causing the oversecretion of cortisol.
Okay, so it's not like you're removing the full kidney.
No.
Okay,
But the adrenal, where's the adrenal gland sit?
on top.
Right on top of the kidney. So very vascular, and my patient could bleed.
Okay, gotcha.
So they would have hypotension if they're bleeding, or if I've messed with the hormone, I can make their blood pressure shoot up. So that's our surgery. Here, someone asked me if you can become a diabetic from having Cushing's disease. Here are the complications of Cushing's disease. High blood pressure, low HDL. Is that the good one or the bad one?
Bad.
That's the bad one. I want that one to be higher. Or
No, that's the good one.
that's the good
H
one.
is the good one.
Sorry, I did
The
that.
LDL is too high. My glucose is constantly high. My cholesterol is high. So what am I setting myself up for? Cardiac events and stroke events. My waist circumference. Does anybody know what the recommendation is for waist circumferences?
40 inches it should be under 40 inches for men, and 35 is for women.
Yeah, 35 for women and 40 for men. So those are but these things, if these are out of control, set you up for type 2 diabetes, cardiac events, and stroke events. So they want to get them under control, but those are your complications. Well, how can I get these things under control? Dieting, exercising.
Waist training.
What'd you say?
Waist training.
Okay. If I need to take a statin to lower my cholesterol, do I need to take the statin? If I've tried to do it by diet and I can't do it, do I need the medication? Yeah, I don't want to die of a stroke. Blood pressure control can be with medication, diet, exercise, things like that. Glucose control. What can I do for that? Exercise, diet. So a lot of this comes back to your lifestyle changes. What's one of the biggest factors? Smoking. Smoking is one of the biggest causative factors of these problems. So give up the smoking. Addison's disease is the opposite of Cushing's, okay? With one other thing thrown in. Aldosterone in Cushing's disease is normal. But in Addison's disease, there's a deficiency of aldosterone. So what do you think's happening to my patient's blood pressure? It's not being controlled, and they're going to be hypotensive, okay? Because I don't have enough aldosterone to regulate my blood pressure and keep it normal. My glucose is low. What do you like when you have low glucose? Cold, clammy. What medley are you like?
Out of it.
cloudy, you're just not with the program, you know. You get a little irritable and grouchy, sweaty. My sodium is low and my potassium is high. What do you think my cardiac problems are? Dysrhythmias, because I know my potassium. And my cortisol is low. I don't have enough cortisol to deal with whatever stresses come my way. So those are my normal labs. This is the test for this, the ACT stimulation test. There's a paragraph in it, your book, on 1275, and it tells you what it is. It gives you very specific medicines and all this stuff. But I just wanted you to know this. It's a timed test. I draw a lab for a cortisol level. I inject the synthetic ACTH, which that's wrong up there. It should be ACTH. And I say every semester I'm going to fix that, and every semester I forget till it's on the screen.
You said that last semester.
I know. In the
Yeah, I
level
think
two
you
one.
did.
Because I duplicate a lot of this stuff because when I'm reviewing, I don't want to give you all new stuff. I want you to recognize it. You know what I mean? I know. I'll say it in 4 too. No, I won't because we don't talk about this in 4 at all. But it's very specific test. So they inject the synthetic ACTH. If you have the response and your cortisol levels are normal, that's a negative test. If you don't respond, they can use that pretty much as a diagnosis for Addison's disease. So just read that paragraph and make sure you know the difference. Which test is for which disease? That's the important thing you need to know, okay? Just say. This can be caused by a bunch of things. If my COPD patient who's been on cortisone or glucocorticoids for years decides he's not taking them anymore, he's going to have a deficiency of all those hormones real quick, and he is going to develop Addison's disease because he just is not producing the hormones himself. It can be autoimmune. It can be related to cancer and TB. Or if I'm in an accident and I have some sort of direct trauma to my adrenals or my kidneys. So if you have somebody who fell or is in an accident and they have some kidney problems, like an injury to their kidney, it can affect their adrenal glands. Okay? Here's your symptoms. Sodium and sugar are both low. This patient has fatigue, they're tired, they're weak. They have electrolyte imbalances because their sodium is too low and their potassium is too high. 2 important ones. Reproductive issues, the low blood pressure, increased pigmentation. Remember when I said we were only going to talk about the melatonin stimulating hormone? Because this patient has an overproduction of melanin, so their skin gets that bronzy color. They have depression and usually some chronic diarrhea that goes along with this. But that's what your patient looks like. Here's your little picture. Sure. You have these slides. They're in your modules. But if you like to write, that's fine.
Have you posted it?
Huh?
Okay.
Are your EAQs out there for this? No.
I saw immunity, but I don't think I saw
I'm going
it.
to kill someone. They have one job. One job. Do the EAQ. I'll check today when we're done teaching. She's going to Memorial tomorrow, but I'll check today. So anyway, here's your picture. This kind of sums up all of that stuff. Here's our crisis over here. If my patient has a fever and they have no blood pressure, they can have convulsions because of the low sodium level, hyponatremia, which could cause the convulsions and seizures, hypoglycemia, severe nausea and vomiting. And I'll show you in the last slide with the complications what our patient's going to look like. All right. So how do you want to take care of them? What do you want to do? Anything? Okay, if they're in the hospital, I for sure want them on a telemonitor because of their potassium. What'd you say? Okay, that's the one thing that they don't recommend that you replace the lost salt unless your patient is outside and losing a lot of salt through sweating, or if they're nausea and vomiting, replacing salt because they're losing it that way. That's the one thing that they don't usually correct unless there's a reason to correct it. Okay? The heart monitor, yes, for sure. Fall risk. Okay, orthostatic hypotension, because if I'm going from, if it's low already and I stand up, my patient's going to fall out. Okay, so I want to check that, make sure that that's good. What else do I want to do?
Give them sugar
Okay.
if their glucose is low.
I want to check their glucose, give them sugar if they need it, glucose, glucagon, something to eat, whatever. Teach them's the biggest one. This is never going to go away. They're going to have this for the rest of their life, so you need to teach them. Teach them to avoid those hot situations where they're out in the humidity, losing a lot of salt. We don't want that to, we don't want to be replacing. They're going to be on a medication. They're going to take this medication the rest of their life. Just because you're better today, because you took it for the last 3 months, you're not cured. It's a lifetime thing. What else might you want to teach them? Diet. Do I want this person using a salt substitute?
No.
No, because they already have too high of a potassium level. I don't want them putting potassium sprinkles all over their food. I'm going to teach them about their medications, which we're going to talk about the medications. Do I need to monitor their electrolytes?
Yes.
Yeah, if they're in the hospital, they're there for a reason. And I need to know what those electrolytes are doing every day. So they're going to monitor them in the hospital. Is my patient going to go have labs drawn every day? Every week? No. But if they're in the hospital. Glucocorticoids. You know everything there is to know about glucocorticoids. You have talked about them with every content topic since you were in level 2. Is that true?
Yes.
So you know how to take care of your patient with that. We don't even have to talk about that. Wash your hands. Stay away from sick people.
Wash your mouth.
You know all about this. The new drug this semester is the fludrocortisone. Okay? And that is a mineral corticoid, and it has aldosterone. It mimics the effects of aldosterone. So I'm replacing my cortisol with my corticosteroid, and I'm replacing my aldosterone with the Florinef. It mimics aldosterone.
But it is still a steroid.
It's a steroid. It's a mineral corticoid. It's a steroid. Yes. You're going to start with small doses of this because a very small dose can control the problem of the adrenal disease, of Addison's disease. It's going to increase their blood pressure. It's going to cause sodium retention, and it's going to excrete potassium in their urine. So one small dose fixes it. Usually what they do is the patient takes the medication every day for about a week till it's under control, and then they take the medication Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. Just 3 times a week. Excretes potassium in the urine. Because that's my problem. I'm holding on to potassium, and I'm getting rid of urine. So I'm reversing that with this pill. The 2 drugs are usually administered together because the problem's a combination problem. It does decrease immunity. So besides doing all the things about avoiding sick people and all that stuff, the other thing with the Florinef is no live vaccinations. So I don't want my patient to get a live vaccination. And my notes here talk about the salt, replacing salt, and not to do that unless there's a reason to do that. What about diuretic therapy? Do you think this patient needs any diuretics? No. If I give them diuretics, I'm creating a bigger problem. So if this patient for some reason has some sort of heart failure, caution with any kind of diuretics. No surgeries to treat it. I already have a problem. I don't have enough. This is what happens. The potassium goes up and causes the cardiac dysrhythmias that are life-threatening. And then you have a severe drop in blood pressure. These 2 are up. Why are these 2 up? Your body's trying to compensate and make up the circulating volume. My sugar's low. What happens if my sugar stays low for too long of a period of time?
You're gonna
Yeah.
pass out.
Well, yes, and well, you can die, but before you die, what is your brain not able to store? Glucose. So before I die, I start having death to brain cells because they're lacking glucose. I might still have oxygen, but I can't store glucose in my brain either, and I have to have it for function. So the treatment for this is to administer your corticosteroids and your Florinef IV to quickly get them out of the crisis, bump up that fluid volume, and then give the IV dextrose to get the blood sugar up. So if I do this with the saline bolus, this is going to correct my electrolytes. This is going to correct my fluid imbalance. And then the dextrose is going to increase my blood sugar and correct the hypoglycemia. So does that make sense? We don't want this to happen. So we need to do a lot of teaching beforehand and teach our patient how to monitor the disease so they don't end up in a crisis. But they need to know how to recognize that they're having some sort of a crisis so that they can get help if they need it. That being said, if I am out somewhere and all of a sudden I have this Addisonian crisis and I can't communicate with you,
They have an ID birth.
yeah, they need to wear some sort of ID on them that says, that they have Addison's disease so that when the paramedics come, they're not starting from ground zero and trying to figure it out, because you're wasting valuable time on someone who can have circulatory collapse. Okay? So, the last things we have to talk about here is the diabetic patient. All right, this should be largely a review, except for the macro and microvascular complications, okay? Diabetes, 2 cycles, 2 negative feedback cycles. There's one, if my blood sugar is too high, I excrete insulin, which utilizes the sugar in the cells. If my blood sugar is too low because I haven't eaten, I secrete glucagon, which converts glycogen back into glucose in my liver. Okay? So this one works 2 ways, if my sugar's up or my sugar's down. Diabetic, it's broken somehow. The cycle's broken. So let's talk about our 2 patients. 2 different kinds of patients. Diabetes type 1 and type 2. In type 1, the beta cells just don't work at all. The patient doesn't have any insulin to utilize at all. In type 2, I have some insulin, and it's either I don't have enough insulin to keep my blood sugar in check, or my receptor cells are not working, and so it's not able to open the little cell doors and let the glucose in the cells. So that's the difference. I have no insulin, or I have a relative amount of insulin, I'm just not utilizing it properly. What's this patient look like, type 1?
They're skinny,
Okay, skinny.
usually a younger onset.
Okay, usually they're diagnosed before their 21st birthday. It can happen after that, but usually it's younger. What were you going to say back there?
I was gonna say younger.
Okay, younger. What else? What do they look like?
They're always hungry.
They're always hungry. They're starving. Because even though they're eating constantly, there's no way for that food to be utilized, and so it's not going into the cells. So they're constantly looking for a source of nourishment for the cells. So really, they're starving to death because they can't utilize what they have. Okay? They're usually skinny. What else?
They have all the problems like excessive thirst, a lot of urine, and excessive
Okay, so excessive thirst and excessive urination. Does that sound like something else? It's diabetes insipidus. But diabetes mellitus has the polyphagia because the cellular death. They're starving, okay? In diabetes insipidus, there's no cellular starvation, okay? What does this guy look like?
Overweight.
Okay, overweight, usually.
Yeah.
Older. Not quite as true today as it was 20 years ago.
With exercise, they can reverse it.
Okay, with the exercise, they can
Control it.
keep it in control. You can't really ever say I'm not a diabetic. You can be a diabetic who has their blood sugar in control. Diet and exercise. Which one of these has modifiable risk factors?
Type 2.
Type 2. There's nothing I can do about this one. It's an they think it's an autoimmune disease, and if it's going to happen, it's going to happen. My friend's little boy's 2 years old, and he was just diagnosed as a type 1 diabetic, and there's nothing she could have done to prevent that. Type 2, I can make some changes. Less sedentary, better diet, things like that can keep me from developing type 2 diabetes. Is there a familial aspect to it?
Yeah.
There is. There's a genetic component to being a diabetic. Gestational diabetes, yes. If your mom had gestational diabetes, there's a higher chance that you're going to develop it when you're pregnant. That's why they have you pee in a cup every time you go to the doctor when you're pregnant.
So both type 1 and type 2 can have a genetic risk
Type
factor?
2 has more of a genetic component than type 1.
Okay.
But I'm sure there's statistics somewhere that show type 1 passed on too. Okay, so we talked about these. Here's some other things that you're going to see in your diabetic patient, especially your type 2 diabetic patient. Slow wound healing. Because they're so saturated with sugar all the time that the wounds just don't heal. The circulation's not good. They don't heal.
Type 2?
Both of them can have these, but you'll see these more in some of these in type 2. I'll tell you which one's type 1. Blurry vision. Can I have that with both?
Mm-hmm.
Yes, because if my blood sugar is constantly too high, I'm going to have changes to the blood vessels in my eyes. And so it can affect my vision. Glucose urea. What does that mean?
You have glucose in your
Sugar
urine.
in my urine. Is that a terrible thing?
Yes.
Am I going to die from that? Okay, I'm not going to die from it, but what happens is I have so much glucose in my system that is just processing through my kidneys and I'm excreting it in my urine. It's really a symptom of my high blood sugar, okay? So, what do you think my patient's at risk for now? Because they have UTIs. If they don't have complete bladder emptying or they're not drinking enough fluid, they're at higher risk for a UTI. UTI and recurrent yeast infections are two of the things that the doctors look for in the older patients. They keep coming back. They can't pin down anything. Then they start looking at blood glucoses because the recurrent yeast infections with the nice, warm, moist environment and all the glucose and the extra glucose in your bladder all the time, UTIs develop. Acetone breath, what is that?
Sugary breath.
Sugary? Is it sugary?
Fruity.
Okay, it's that rotten, fruity, smelly breath.
Okay.
And what that is from is you are burning ketones because you're starving. Your cells is saying you don't have enough food, so we're going to burn some fats to get you some nutrition. And then the byproduct of that burnt fat is the acetone breath. That's why the keto diet works, because you're constantly in fat burning mode. That's why they all have terrible stinky breath too. Ew. But it works because you're constantly in that mode where you're burning fat. I don't advocate the keto diet, I'm just saying that. Let me put that out there. It's hard on your kidneys. My brother-in-law has kidney failure because of the keto diet. So I don't advocate it, but that is why it works. Here's your normal blood glucoses. Remember when we're diagnosing our patient, we can do a random blood glucose. Just, she ain't acting right, let me check her blood sugar, okay? There's nothing wrong with that, you can do that. But if I have a random glucose of greater than 200 with some symptoms, they can use that as a diagnostic tool. Okay, could she have just eaten 12 Krispy Kremes and just be acting goofy? Yeah. So it's not a be-all, end-all diagnosis. The oral glucose tolerance test. Who does this? Usually.
Lab.
Usually.
But pregnant people do.
Yeah. I mean, which patient? Not doesn't. I know the lab. Which patient? Usually, you're going to see that done on your pregnant clients, and you either eat that sticky, icky, sweet breakfast, or you drink the sweet drink, and then they draw your labs. Greater than 200 is a positive test for a diagnosis of diabetes, and particularly gestational diabetes. Fasting glucose. I have to have 2 consecutive readings of over 126. So, if I tell Justin, we're going to get some fasting glucose levels in the morning on you, and then I say, I'll see you, in the morning, shut his door. Do I trust him to not eat? No. So I really need my patient to be fasting for 8 hours. Some patients don't understand that. You can drink water, but you can't eat or drink anything with any kind of calories or sugar. So it's not completely reliable, and I want you to know this is not right. This is out of your book, but it's not right. In your book in another place, it's 120. So 70 to 120 is your normal glucose. And I have worked to the 80 people to get that corrected in your book.
What do you want to do? Yeah, that's the group.
120 to 70 to 120 is normal. This is your test right here to diagnose and monitor your patient, your A1C. Why is that a good test? It shows for 3 months.
3 months.
Okay, it shows a history of 90 days of how well you controlled your blood sugar. And I meant to put it up here in the new book. You're in edition 9, right? Mm-hmm. There's actually a chart in there that shows you if my A1C is this is what it would equal as a daily average blood sugar. And so you can see that the higher the number is, the higher the average daily blood sugar is. Can patients lie on all 3 of these tests right here? Yes, they can lie on those. Because I know I'm going to the doctor, so for the 3 days before, I'm going to be perfect, I'm going to fast, I'm not going to eat anything with sugar in it, and I can manipulate those blood sugars that they're just doing randomly. This one, I can't manipulate that very well because I can't be good for 90 days, so I can't manipulate that one as easily. So this is the one that they routinely use to confirm a diagnosis and to monitor how well your patient's doing on the plan. The acute complications. Okay, hypoglycemia is one of the acute complications. And where did it go? I had it in here. Okay, let's talk about these. These are level 4. We're going to learn all about teaching your patient what to do to prevent these hyper problems. We're going to talk about the hypo problem, low blood sugar, less than 60. Or if my patient had a super high blood sugar, like let's say they had a blood sugar of 400, and I gave them a whole bunch of insulin, and I go in and check it, and it's 80, how do you think they're going to feel? They're going to feel terrible. The goal is to reduce the high blood sugar by 75 an hour. So if I drop it 300 in 1 hour, they consider that hypoglycemic at that point. Okay? So, diaphoretic, clammy, don't feel good, irritable, foggy memory, could have some vision changes for my hypoglycemia. What am I going to do for them? There's all your little things right there.
Give them candy.
Okay, give them candy. Okay, candy's not the best, but that's a good saying.
Graham crackers.
Orange juice. How much orange juice?
8 ounces.
I hear 8 ounces and 4 ounces. Which is it? It's 4 ounces of orange juice and 8 ounces of milk.
You can give soda too.
That equals 50.
If I only have soda,
4 ounces.
I can give some soda if that's all I've got available. Because it's better to treat the hypoglycemia with something than to ignore it because I don't have orange juice or crackers or whatever. So if you go to the school nurse, like a kid goes to the school nurse and they have hypoglycemia and they don't have juice, they're going to get soda. Okay? I can give lifesavers. Is one lifesaver going to do it?
No.
I think your book says 4 to 6 lifesavers. Crackers with peanut butter. The goal is to give them a little bit of glucose to get the blood sugar up and then a little bit of protein to help keep the blood sugar up. So that's my goal. If my patient's conscious, I want to feed them. Okay? If they're unconscious, I still got to take care of them. So I'm going to use glucagon or D50. Okay? Glucagon, I can give it sub-Q I can give it IM. They have a gel that you can put under the patient's tongue that's kind of dissolved in their mouth to raise their blood sugar. Here's the problem with glucagon.
It goes fast. It goes back down.
It can go back down fast. If I'm only correcting the blood sugar but not really the problem, my blood sugar could drop. It makes you nauseated because what happens in that negative feedback cycle where the glucagon converts glycogen back into glucose, when I do it because I'm a little bit hungry because I should eat at 12 and it's now 1, my body knows to only release enough to bring my blood sugar up. When I give this dose of glucagon, there's no control there. It just converts all of it back, okay? And that big boost of glucose is what makes you nauseated. And then if I repeat it, there's no more glycogen to change back. So I only can do it 2 times. So I can only give glucagon twice. If I give it 3 times, it's not effective because I've already converted everything back. I can give it, which is not going to work. So as soon as my patient's awake and able to, what do I want to do?
Feed them.
I want to feed them that carbohydrate snack to keep that blood sugar up and look for what my problem was. Was it that my patient didn't see the insulin syringe and gave himself too much insulin? Or did they give themselves insulin and they didn't eat anything? That's a teaching thing. I got to teach them if you're going to take it, you got to eat. So I got to investigate what the problem was. 50% dextrose. What do you remember about it?
You only give it twice.
No, you can give it forever. You give it IV.
Tissue damage.
Causes tissue damage. If I don't have a good IV, I can cause all the underlying tissue to be necrotic from all the glucose being underneath the skin. So they'll have to make sure that my patient has a good IV. How fast can I push D50? Fast. You just as fast as you can. It's very thick. It's like pushing pancake syrup. So as fast as you can without blowing your IV. And normally what you're going to see is they're going to have orders for 1/2 of an amp of D50 and then check the blood sugar in 30 minutes and then another 1/2 an amp if it doesn't come up. Usually as you're pushing the dextrose, you'll see your patient becoming alive. And what do I want to do when they become alive? I want to give them something to eat. You know, you look like you need something to eat, so I'm going to give you something to eat. It did? Hey, who in here had the patient that had hypothyroidism and the pulse of like 15?
Yeah.
You didn't say a word the other day
No,
about
I
that.
thought it was hypo, so it was saying.
Oh,
I didn't want to be like, yeah, I had a patient.
Yeah, Miss
So I was
Cooper's-
like, well, that's my.
yeah, Miss Cooper said someone in my group had a patient with a pulse rate
Yeah,
of
she was on a
15.
ventilator and then we had to keep her sedated the whole time because she kept trying to pull her.
Yeah, so when we get to talk about mixed edema coma, you're going to know all about it in level 4, right? You can pull out your care plan and you'll know everything. That would have been a good one to talk about. Okay, so I've got to make sure my IV is good. I can give this as many times as I need to. But after my patient starts rousing around, coming around, I want to give them something to drink or eat to keep their blood sugar up. Investigate the cause. Figure out what caused the problem. Diabetic ketoacidosis and hyperosmolar non-ketotic syndrome are 2 of the acute complications of hyperglycemia. They both have high blood sugars. Diabetic ketoacidosis is over 300. HHNS is over 600. Diabetic ketoacidosis is usually your type 1 patients. HHNS is usually your type 2 patients. They are both medical emergencies. So you need to know how to recognize them in here, but we're going to learn how to treat them because they're life-threatening in level 4 and what you need to do to protect your patient and keep them alive. So we're going to skip the acute complications of hyperglycemia. What is that right there? What do you think that is? Huh?
Sugar.
It's a sugar molecule. It's pretty, but as a what? As this all jaggedy molecule is floating through your bloodstream, what do you think it's doing to your blood vessels? It's tearing them up. It's tearing up your nerves, and it's tearing up your blood vessels. So that's how you get your chronic complications associated with diabetes, okay? Can this be prevented, the complications?
If you don't eat it, yeah.
If you don't eat it? What do you mean?
Like if you cut down on your sugar.
Okay. So in other words, she's saying if I can control my blood sugar, I can prevent these chronic complications. The whole key to preventing these complications is tight glucose control for the patient. Okay? Is that easy to do?
No.
Nope.
Everything
Now, let me say this in defense of that. The patients that you see in the hospital are usually the ones who are either non-compliant or who have other comorbidities that cause problems with their blood sugar. So you don't see the 80% that are out in the community who live with diabetes every day and who do have it under control. So we're speaking strictly from the healthcare professional and all those dang non-compliant patients who don't do what they're supposed to do and end up in the hospital and lose their toes and eyesight. See what I'm saying? But if you look at it as a relative population of diabetics, there are hundreds of thousands who do exactly what they're supposed to do and don't have all these complications. But unfortunately, we're going to take care of the ones who do have complications. Well, let me put a plug in here too. If anybody is interested when they get out of nursing school in the diabetic educator, being a diabetic educator, you do have to have a master's degree, which, you know, you can do RN to master's degree. Hold on though. In the state of Mississippi, I believe the last statistic I read, there are 47 certified diabetic educators in the state of Mississippi. Now, we are known as the what?
Obese
Most unhealthy, obese state with 47 diabetic educators. Of one, Miss Coleman is one, and she's not educating the public about their diabetes. So now we're down to 46. And how many other ones are not out there? How many other ones are not working in that profession? It is a booming profession if you're interested in this at all.
Do they pay good?
I don't know, but I can give you the name of somebody who knows all about it, who can talk to you from Ocean Springs. But there's a huge market for diabetic educators if you're interested in that at all. Think about it when you get out of school. So, let's talk about these complications. Macrovascular. Macro, we're talking about the big vessels in your heart, in your brain, and peripheral artery and vascular disease. The big vessels, okay? Microvascular, we're going to talk about these three because these are the ones you're really going to see mostly in the hospital. Retinopathy, the loss of vision, kidney dysfunction, because almost all of your chronic kidney patients are what?
Diabetics.
Diabetics. They started out as diabetics. And then nerve dysfunction. We're going to talk about peripheral neuropathy, which that should be kind of a review because we talked about that with the foot care in level 2. But the rest of these are new. So cardiovascular disease with this patient, higher risk or lower risk? Higher risk. They have a higher risk for heart attacks and strokes, both. And when they have those, they have worse outcomes because they already have other things going on. The high blood pressure, the high glucose levels that they have all the time are the main cause of these complications because they allow the vessel damage to occur. And then when the heart attack happens, they take a longer time to recovery. They just don't have as good a recovery time. Chronic hyperglycemia is the main thing that increases their risk. They have other risk factors, the sedentary lifestyle, the obesity, hypertension. Diabetics almost always have hypertension that's not controlled well. The diabetics we see, let me put it that way, the ones we see. When I say that, we're talking about the ones that we see in the hospital, okay? For every point, so point 1, point 2, that they can decrease their A1C, they decrease the risk of cardiac and strokes by 25%. So if they can keep reducing that, they can get this risk factor under control.
So is
Say
it
that one.
decrease it like by every 0.1 or
I'm sorry, by 1.0.
by one?
So every point that they can get it down, they decrease it by 25 to 30%. That's a lot. You guys, when you went to your ASLS, didn't she tell you there that most of these strokes could be prevented? And it's one of the largest healthcare costs to the American population. Isn't that sad? That you could prevent some of this stuff from happening if you just do what you're supposed to do. My thing is broke. Left-sided heart failure is big with diabetic patients. So what are my symptoms if I have left-sided heart failure? What'd you say? Yeah, pulmonary problems. So that ties in my respiratory system to that. Let's see what else. The solution: monitor your glucose, aggressive therapy to keep it in check, and control your hypertension and your hyperlipidemia. And those are all risk factors that you can reduce. Diabetic strokes, 2 to 4 times higher in a diabetic patient than the normal population. And the risk of the stroke happening from cardiac vessel obstruction is way higher in your diabetic patients. So the whole teaching is super paramount in keeping these problems from happening with the patient. PBD, what's this glucose molecule doing to the vessels in your legs and arms?
Decreasing circulation.
It's decreasing circulation, it's tearing up those vessels, and what happens? That's why they lose their feet. They have a wound that doesn't heal. I have poor circulation to that wound, so I have slow wound healing, and then I end up having my toe, they like to do this one at a time. 1 toe, 2 toes, half the foot, up to the heel. They do. It's a prolonged thing because as they're cutting off 1 toe, they're hoping that heals. And if I don't make some changes to my glucose level, what's going to happen to my surgical incision? It's going to get infected, and then they're going to take 2 toes. It's a vicious cycle. But amputations are highest most amputations, other than ones that are caused by an accident, are caused by patients with uncontrolled diabetes. So, can be controlled. Okay? Here are your ADA recommendations. And I don't think you remembered. Oh, you have some things back there. So, the blood pressure, 130/80. That is the recommendation. If you are a diabetic and you have hypertension, that's your goal. 130/80 to get your blood pressure there.
Even for the elderly?
Huh?
Even for the elderly?
For a diabetic patient, that is the ADA goal. And your elderly people have lower blood pressure than that. You know what I mean? So you might have trouble getting them that high, so it would be lower. LDL. If you have a cardiac history, less than 70. If you don't have a cardiac history, you get to be 100. But I just told you, most of these people have some sort of cardiac history going on. Because is having high blood pressure part of a cardiac history? Yeah. HDL, more than 65. What kind of things can you tell them to increase their HDL? Cheerios, oatmeal. This is what my doctor, what'd you say? Fish oil. This is what my doctor told me. You need to stop eating pastries and ice cream and take your fish oil. My LDL was 102. I'm like, I think I can live with that. I'm okay. I'm going to eat
I'm going to eat the damn thing.
right. That's what she said. We need to keep working on that. It's 102. I didn't have my lab book in front of me, but I said, is it 100 okay? I'm not a diabetic, but my A1C, less than 6.5. So the high end of normal, that's where they want their A1C to be. And then they want to do the risk factors. Anything that can be modified. So, can I modify my blood pressure?
Yeah.
Can I modify my lipid levels?
Yeah.
My cholesterol levels? Exercise, no smoking, diet, get my weight under control, I can fix some of those things. Those are the goals. Here's our macrovascular problems. Retinopathy in the eyes, and we're going to talk about two different kinds. I think they cover like 4 pages about retinopathy in your book. You know, it's like, I'm going to tell you what you need to know. I mean, read it because it's important. It gives you some stuff. I'll tell you what you need. Kidney dysfunction, patients with acute renal failure that progresses into chronic renal failure, and then nerve dysfunction with your peripheral vascular or neuropathy. So let's talk about the eye first. This is the normal eye. Can you see this one over here has all these little deposits on it? That's where the sugar has tore up the blood vessels. So 2 kinds of retinopathy that your patient can have. One is called non-proliferated retinopathy, and that means that the little glucose molecules are clotting off your vessels and you're not getting blood supply to your eye. Remember what we talked about retinal detachments? If I'm not getting a blood supply to my eye, that part of my eye is dying. So non-proliferated means that I have a blockage and I'm not getting blood supply. The other one is proliferated diabetic retinopathy. And what that means is my eyes, because I had this in the first place, I've developed all these blood vessels that weren't supposed to be there, and they're real fragile and leaky. And so I can have hemorrhages in my eyes that cause blindness. So proliferated means that I have extra blood vessels that have developed, and they are just not stable blood vessels, and I have hemorrhages. Those are the 2 kinds that you need to know about. How can I prevent that from happening? Control your blood sugar. How often does my patient need to go to the eye doctor and have their eyes checked?
Every year, right?
Every year. It's an annual eye exam. Do I need to be picky about who I go to?
Yeah.
They need to know about the case.
Yes, I need to go to an ophthalmologist or an optometrist. Which one? Ophthalmologist is a medical doctor who is also an eye doctor. An optometrist only specializes in just what lenses you need to fix your vision. They don't do all the extra testing to make sure that you don't have any kind of eye problems. They're the Walmart doctors. They are, for real. The Walmart doctors are,
It's a great value.
yes, they're the great value.
If they saw that, they would send you to your,
Yes, they would.
they still would adopt
They're real doctors. They're real doctors.
Look, she worked this.
Well, they're real doctors. And if they see this happening, someone said over here, if they see this problem, they're going to refer you to an ophthalmologist who specializes in this. Okay? Because that's what you need right there. Peripheral neuropathy. The blood sugar is tearing up the nerve cells. Okay? It affects all parts of the body. What happens is hyperglycemia causes those blood vessel damages. It decreases perfusion and causes hypoxia to the nerves. So I'm not getting the oxygen and the blood flow that I need to my nerve cells. It destroys the myelin sheath. So what do you know about nerve impulses?
They won't travel as fast.
They don't travel as fast. So it chews up the myelin sheath and my nerve impulses are not going through. Your patients can have that burning sensation in their feet, or they can have no feeling in their feet from the blood vessels or the nerve cells being torn up. The other thing that happens is, you know what sorbitol is? It's that sweetener that they put in stuff that causes diarrhea. Did you know that? If you eat a bunch of diabetic candy that's sugar-free, yeah, the sugar-free candy is full of sorbitol.
Always get lots of
All right, everybody hear that? If you ever need a laxative, you eat the Russell Stover sugar-free candy. Because the sorbitol in it will cause diarrhea. But the sorbitol also collects around the nerves and causes nerve damage. So glucose is converted to sorbitol. So I have all this extra glucose I don't know what to do with. I'm converting it to sorbitol, and now it's all collected around my nerve cells, causing nerve damage. So that's how this happens with your nerves. The most common place that this happens is in your feet. So what do I need to teach my patient about foot care?
Examine their feet daily.
Examine their feet daily. Every day, not once a week, every day. No hot baths.
No
Don't
lotion.
cut your own toenails.
Okay, can I have no lotion?
Not between the toes.
Okay, I can lotion my dry, crusty heels.
Yes, please.
Thank you. But I don't want it between my toes because if I have any kind of moisture in there and I have the lotion, I'm setting myself up for yeast infection.
Yes.
Who said don't cut your toenails?
Melissa, somebody over here in the white coat.
Okay, don't cut your toenails. Who's supposed to cut your toenails?
Podiatrist.
The podiatrist. I can't go to the podiatrist. I don't have any insurance for one, and my work will never let me off to go.
File them.
Okay, I can file them, and if I do cut them, I need to cut them straight across, no corner edges in there. Okay, take a break, y'all. Come back at the top of the hour.